Thank you for the opportunity to present our research here. Our study is entitled How to Use and Analyze Longitudinal Observational Data to Study the Effectiveness of an Intervention. Registries or big data are a very good source of real-world data, and especially in surgery, when randomized controlled trials can be difficult to perform. Common examples are the MD-APNet, as just been discussed. And these types of data are longitudinal observational data, in which a patient is included into the registry and is followed over time. However, as Marushka already mentioned, these types of data are prone to confining by indication bias, in which the probability to receive treatment can depend on the patient's baseline characteristics. So more severe patients with a more severe disease state are more likely to receive treatment compared to patients that do not. So when you evaluate these patients over time, you will might find a difference at the end that might not be attributed to the treatment itself, but to the baseline characteristics of the patient. There are several statistical methods that have been proposed to address this type of bias. And one of the most common methods is propensity score matching. What as Carl already mentioned, inverse probability weighting is also a method, G estimation, parametric G formula, or the time-dependent propensity score matching. In propensity score matching, you will match most of the time at baseline on the baseline covariates of a patient, like age, gender, or disease-specific parameters. And you will try to create a randomized control trial, mimic a randomized control trial, and create a balanced group. So we only keep those patients that we can match to control patients to create a comparable cohort. However, when the moment of treatment varies, or there are multiple moments in time that the patient will receive a repeated treatment, this balance at baseline might not hold or might not be valid anymore at the moment that the patients receive treatment. So when the patients go towards the treatment, one disease state might worsen, and therefore the balance between these two groups might not be true anymore. So therefore we were wondering, how do we deal with this type of bias in longitudinal observational data when a treatment might be at a later moment in time? And secondly, if we know which methods have been used in the past, how do they affect our own empirical data when we try all the methods at the same time? So first, we performed a systematic review to look into the literature, which methods have been used in longitudinal observational data, and extract what the moment of treatment was. So was it at baseline, is it a fixed treatment, or was it a time-varying treatment? Secondly, we performed all these methods on our empirical data from previously published data set of the Osteoarthritis Initiative. The Osteoarthritis Initiative is a large observational cohort study from the USA, which included over 4,000 patients, and the inclusion was between 2004 and 2006, with a 9-year follow-up. And we tried to replicate a previously published study that looked at the meniscectomy, cutting a piece of the meniscus, and the risk to receive knee replacement surgery at a later moment in time. So, on to the results. We started our systematic review with over 2,000 papers that we've identified, and after our exclusion criteria, only 760 remained. And we've categorized them according to the moment of treatment. So for the first, the fixed treatment, we've detected 201 papers. And the most common method to correct for this type of bias is propensity score matching at baseline with 163 papers. And as you can see, there are a lot of other studies, but they are lower. Then we move on to the time-varying treatment. We found the most papers, 490 papers. And the method that is used the most is inverse probability weighting with 149. But at the second place, we find propensity score matching at baseline with 123 papers, which is 25% of the studies that we have included in our systematic review used propensity score matching at baseline while they had a time-varying treatment. So then when we tested these methods on our own empirical data set, we first tried the baseline methods, like propensity score matching at baseline, inverse probability matching only at baseline, and we found a hazard ratio around 3. And then when we tried the time-dependent methods, like time-dependent propensity score matching, parametric G formula, the hazard ratio we found was a bit lower, around 2. So to conclude, propensity, in our systematic review, we found that propensity score matching is still the most common method in longitudinal observational data. And even in the presence of a time-varying treatment, in 25% of the papers that we found, it is still being used. And this can lead to incorrect results, potentially. In our own empirical data, we found higher estimates when we use the baseline methods compared to more advanced methods that do take the time of treatment into account. And therefore, we recommend to use time-dependent methods like inverse probability weighting to preclude this. And therefore, as a take-home, if you're dealing with real-world data with a time-varying treatment, that can be challenging, and use IPW or ask for help. Thank you very much.